So you're the associate professor of medical imaging, that is radiology, and you're also an associate professor in surgery.
I started in surgery, and then the program got approved as a 7-year program, and then I transitioned to doing 4 years of medical imaging.
The walls of the silos are being broken down and people are being brought together.
Everybody talks about thinking outside the box, but I think before you can think about the box, outside the box, you need to kind of know what's in the box.
So Eran, I know that medical school, the pathway to become a physician is just super long. And especially when you take the academic physicians, in addition, you've got to do all your fellowships and stuff like that. So for me personally, I started my med school in 2003, and then my first staff position was 2018. So it took 15 years of everything. And that, I'm just a radiologist. You decided to be not just a radiologist, but also a surgeon as well. So what inspired you? What madness drove you to get trained not only in radiology, but also in surgery?
Yeah, I mean, it's a great question. I mean, I guess my pathway in this hybrid training is really just a function of the physicians and the mentors I met along the way. So I was fortunate enough as a pre-med student to get an opportunity to work with kind of a really innovative interventional radiologist at the Hospital for Sick Children, Peter Chait.
Mm-hmm.
He was really kind of a visionary back then, super clinical interventional radiologist, very involved in patient care. And as a pre-med student, I came and worked with him, and I saw the work that he was doing in interventional radiology in kids and babies, and I was immediately hooked. And I thought this was the most amazing thing ever. He was using kind of cutting edge technology to help these patients, and I really wanted to do what he did, and got into med school, did med school, and I really liked surgery as I was going to med school. And I had a kind of a bit of a dilemma what to do when I was graduating and applying for residency. So he was one mentor. I came to him, and we had a lot of conversations about what's best to do and how we can try and combine it. And I think kind of what came out of that is that there's probably a need for hybrid training between surgery and medical imaging. And he was really, I guess, one of the visionaries of kind of showing me the pathway and what it could be. And we wrote a little review paper talking about the need for hybrid surgery and hybridization of surgery and medical imaging and interventional radiology. And I was applying to residency, and he in the background took it to the head of the Department of Medical Imaging at that time, Walter Kucharczyk, and the head of the Department of Surgery was Richard Resnick. And they were both, kind of obviously giants in the field and very focused on education and trying new things. So I got into residency, and in the background, they made an application to the Royal College of Physicians and Surgeons to try it as a trial program. I was going to be kind of the guinea pig, if you will, for the first one. But the plan was to have a couple of people go through it every year, and it was going to be a 7-year program to do combined surgery and medical imaging. And I actually got final approval a couple months before I finished my PGY 1 year. So I finished my PGY 1 year in surgery.
So you took PGY 1 with surgery, you took surgery, and only then you figured...
Yeah, and only then the program got approved.
Mm-hmm.
So
you were in a program without even knowing.
Yeah, exactly. So I started in surgery, and then the program got approved as a 7-year program. And then, I transitioned to doing 4 years of medical imaging. Part of that was interventional radiology. And then I wrote the Royal College exam in medical imaging, and then went back and completed my surgery training.
So you had to write 2 separate exams for both.
2 separate exams for both, but it was busy, but it was really kind of amazing time. And then
it needs a certain caliber of person to say that it was an amazing time to write 2 exams separately.
It was busy. It was definitely busy, but I was, working towards a goal, and obviously I couldn't disappoint the, I guess, trust that was placed in me.
And the pressure because they've created a whole program just for you.
Yeah,
So it's
yeah. There's
an added
definitely
pressure that you have to make it succeed now.
yeah. There's definitely, I guess the whole program would sink. I guess if I if I didn't succeed, but I really enjoyed myself. I mean, I had a lot of support along the way from really both departments. I've never really faced uh, much in the way of resistance or why is a surgeon coming to uh, radiology, or why is a radiologist coming to surgery. Everything went quite smoothly from that perspective. I think it's really a testament of kind of U of T and like the openness of the program here to trying new things. And then I graduated, and I was lucky again that I went to do my fellowship in Portland with another kind of very visionary surgeon, Lee Swanstrom. And he was somebody that has been around long enough to see two transitions, from open surgery to laparoscopy, from laparoscopy to endoscopy. And when he saw my training, he was, kind of saw the potential, and luckily gave me an opportunity to come and work with him. So I got a chance to work with him, and then we were chatting a little bit before he got me involved at doing some research at the Institute for Image-Guided Surgery in Strasbourg, in France. So I've been lucky enough to work there and try and develop some of these skills, and then coming back to Toronto, they gave me they took a chance on me and hired me, and
Oh,
hopefully they're not regretting it.
it's a perfect story. I mean, your mentors kind of seem like mine. So you were inspired by a radiologist, you wanted to do surgery, you go and ask your mentor, he's like, why not do both? And you end up doing both.
That was exactly it. I mean, he was Peter Che was very visionary. I mean, he was the kind of interventional radiologist who would go and round, on the patients on the ward, and see them there, and round with the clinicians, and really kind of gave me a vision of what the specialty is, and how embedded you are in patient care, which was
So it
really
takes his job as a clinician, as a physician, very seriously.
yeah.
I think that it's also testament of great leaders when they spot people like you, people with caliber and promise, that they are willing to change and create something completely new. Because we've had this discussion previously, because a lot of times we operate in silos and we don't really know what's happening in other places. But it's great that these leaders were able to break down barriers to create this thing entirely for you. And it's also a testament of how much potential you showed even at the beginning of your career.
Yeah, no, I was very lucky, to meet the right people at the right points in my life and in my training that saw the potential and believed it could happen. I mean, I was, a medical student and a junior resident, so obviously they did a lot of the heavy lifting in the background to see the program kind of come to reality. And I've benefited from that, greatly, and I'm immensely appreciative for all the work that they've done.
It's one thing to get trained, because, it is tough, it is grueling, but you finish 2 residencies combined, write 2 exams. But then it's a whole another thing continuing that expertise, because things keep evolving and things keep changing. So what challenges do you face trying to keep up with competencies in both spheres, especially because although they are complementary, they're slightly different. Like imaging is, the skill sets required are very different from surgery. So what challenges do you face, or do you face any challenges keeping up with them?
Yeah, no, for sure. I mean, surgery is very broad. Interventional radiology is very broad, and they only continue to expand. So I really have tried to focus my practice over the years on areas where I can kind of bring value added from both fields. So over time, my practice has really focused down on areas where I feel I can really contribute. So right now I do the majority of my surgical practice is in endoscopy and therapeutic endoscopy. And in interventional radiology, I've focused on sort of angio, non-vascular imaging
Mm-hmm.
and non-vascular interventional radiology, because I think that's really where I can, most help patients, combining endoscopy and IR and some surgery, and
It's
sort of trying to help patients with these skill sets has been really amazing.
interesting. So essentially, if it is, for example, it's a drainage, if it's a vascular intervention which an interventional radiologist can handle, then they'll call them. If it's laparoscopy, if it's surgery, if it can be handled by a surgeon, they'll call the surgeon. But then if both can't handle it, if it's like an Avengers level threat, then you're the final boss. They call you, and then you come in with skill sets in both, and you solve and save the day.
Yeah, I mean, I think for certain things, it's become very useful, and it can be even from the kind of just mundane, even gallstones and complicated patients. We run kind of a complex gallbladder clinic at UHN for patients who are sort of on the border of, are they okay for surgery? Are they not okay for surgery? And trying to make that decision. And if they're not okay for surgery, what can we offer them in interventional radiology to manage their symptoms? And then taking it to the, more exotic procedures of trying to, use magnets with endoscopy to open up, blockages in the esophagus or the.
Sorry, you're saying you use magnets? How is that? How does that work?
Yeah, so for the first case we ever done was a patient with a tongue-based cancer post radiation, had complete occlusion of their proximal esophagus to the point that they couldn't really even swallow their saliva.
Was it due to the cancer or due
to the radiation?
Due to the radiation.
A benign occlusion of the upper esophagus. So he got referred to us to see if there's anything at all that we could offer him. He didn't really have any surgical options, and obviously his quality of life was quite poor. And we were trying to see if there's anything we could do. And the concept of magnetic compression anastomosis is not new. I mean, it's been done before in the biliary tree, and it's been done before in kids for esophageal atresia. But in adults, it wasn't as well described. So I think he was getting fed from a gastrostomy tube, and we kind of used our skills in interventional radiology to reach his distal esophagus through the gastrostomy tube site, and then his proximal esophagus, from the mouth. And we placed 2 magnets there, and they basically create a compression anastomosis. And we were able to recanalize his esophagus, reopen his esophagus, and he went from the point of not being able to swallow his saliva to the point where he was able to tolerate food, and we were able to take out his gastrostomy tube, and really, had a marked improvement on his quality of life. So,
So let me get this right. So the esophagus, which is a tube, is just completely narrowed. So then you take a magnet through the top, place it here, and through the stomach, you put a tube in, go up, place another magnet here. And these two, because they oppose each other, they're able to kind of go through and create that opening.
Yeah.
Wow, that is incredibly smart.
Yeah. And luckily it worked very well. We've done a few cases for the biliary tree in patients after liver transplantation where the anastomosis has occluded. We've done it in the ureter one time as well. So that's more to the, I guess, extreme of where you can combine, interventional radiology and some of these surgical and endoscopic techniques.
Wow. That is incredibly creative, thinking of like very unconventional ways to deal with problems. Because otherwise, I think the only other way is just to cut open everything and try and cut it out and just re-anastomose it. But this, in a very weird kind of, quite often, like at home, we have these like solutions in which you do it yourself in a fun way. But this is like actually impacting patient lives in very unconventional ways.
Yeah, I think these patients really came to us because they had very few options, and we just wanted to see if we can help them. And I think we're very lucky at UHN. We have access in our hybrid room in IR. We have access to every piece of technology you could possibly want. We have our CT, our fluoro, our we have our mobile endoscopy tower there. So it's really kind of a unique place where you can bring all these modalities to try these more kind of out there cases.
Yeah, you need all these building blocks or Lego blocks, if you will, but you already also need someone really, really smart to put those together in a beautiful fashion, right? So how do you come up with these ideas? For example, the gallbladder one you were telling about, how do you come up with the idea and how do you kind of test it?
I think the ideas really come from patient needs. I mean, the gallbladder, where we create a percutaneous anastomose between the gallbladder and the duodenum, that came from patients that really didn't have any options, either have advanced cirrhosis or advanced malignancy, and they can't have their gallbladder out, but their cholecystostomy tube continues to give them problems. Where we try to see if we can have a solution for them.
So you're saying that like when patients have gallbladder problems and when they're too sick to have surgery, the only option is putting in a cholecystostomy tube, but now they have a tube sticking out. So instead, you put a tube in connecting the gallbladder with the duodenum so that it drains internally.
Yeah, so we put a stent between the gallbladder and the duodenum, and that's been done before with endoscopic ultrasound guidance, sort of from the inside to the gallbladder, from the duodenum to the gallbladder. But there's certain advantages we think to doing it percutaneously, so straight through the skin into the gallbladder. So we had a few patients that kind of needed that solution, but the solution wasn't really available. So we did some work in Strasbourg on animals there to try and figure out how to exactly do the technique percutaneously.
Okay, so it's tested first before to like...
Yeah, so we tested it first, and then really we had some patients that really didn't have any good options at all, and we started doing it in human and the first human series, and now we've done 18 patients with kind of this percutaneous solution to their gallbladder, and it works quite well. It works quite well in kind of difficult situations. So we've been happy, kind of this translation from kind of the lab or animal work to kind of impacting patients.
Yeah, so it's first identifying a need, then thinking what could be a good solution, and then having enough of networking. And as you point out, you're doing all of these animal research in France. So having the network and connections to be able to do that, like procure the animals, like refine your techniques. And then when you're confident, then bring it back and apply it on patients to solve real world needs.
Yeah.
This is just truly pioneering and truly innovative.
Yeah, I mean, again, I've been lucky to have a lot of support, both, obviously in Strasbourg, but I guess maybe more importantly here in Toronto, both on the surgery side and on the interventional radiology side to kind of see these things through and try to help patients as best as we can. So I've really benefited from the infrastructure, which has been extremely supportive.
And in terms of infrastructure, what do you think is going to be next? Like we kind of heard a lot about augmented reality, the HoloLens and all that stuff. Like, are you using it? Do you still see that it has a huge role to play? And then also, what about like robotics on one side and then AI on the other side? How are they all going to come together?
Yeah, that's a great question. AI is obviously taking over the world, and surgery is not going to be any different, and IR, I'm sure, is not going to be any different. I mean, we're seeing a lot of solutions coming online for surgery. I mean, one of my colleagues, Amin Madani, is working on a kind of intraoperative AI tool to help you see what are the safe areas to dissect during laparoscopic cholecystectomy.
So real time, the AI is able to look at the video and point out which are safe and unsafe areas to dissect.
Exactly, which is quite amazing and revolutionary. In endoscopy, we have a system that helps you detect polyps, which has
So I've heard that, like especially in the colon, the polyps can hide behind the folds and all that stuff.
Can hide behind the folds, or even you can it's sometimes you just need an extra pair of eyes, you know, and it really provides you that extra pair of eyes to see the polyps that, you know, you may have otherwise kind of slipped by, and it's really amazing. And these technologies are only getting better. I mean, I'm involved with a company that's using AI for some intraoperative decision support around anastomotic leak and anastomotic testing. And you know, in radiology, obviously, I don't have to tell you that AI is going to really come and change everything.
Yeah, diagnostic side of things. Yeah,
Yeah.
a lot of things are going to be very different.
Yeah, absolutely. So I think it's an exciting time in medicine. There's going to be a lot of transitions that are going to happen in the next 5 to 10 years. It's really going to be interesting to see where things go.
Yeah, and what about the robotics in general? Do you think that we'd ever reach a point in which you can be in one country, but you'll be performing, or like one province or one city, you'll be performing surgery in a different place, kind of routinely? I know that once in a while it's being done for the hype to show that it's possible, but like, do you think that that'll become more commonplace?
Yeah, I think so. I mean, I've come maybe full circle, I think, on or maybe not full circle, but 180 degrees in my kind of idea of robotics and the role. You know, when I trained in my fellowship, we didn't really use robots, so I was a bit of a skeptic, I guess.
Mm-hmm.
But just seeing the impact of robotics on surgery and what it can do as far as, you know, patient outcomes and the comfort of the physician in performing the surgery and sort of elevating your technical performance in performing surgery. I think robotics are definitely here to stay, and maybe in large part over the years will take over. And same thing, I think, for interventional radiology. There's a lot of room for innovation. You know, if I don't have to be in the room or exposed to radiation, and the robot can do it for me, then, you know, by all means. And for flexible endoscopy, I mean, flexible endoscopy is quite technically challenging and demanding. You know, there's a lot of companies that are working on flexible platforms, and, you know, once those come into real clinical work, it's going to make a huge impact on what can be done through kind of a natural orifice versus needing to operate on the patient to resect a segment of the bowel. So it's the technologies that are coming online are really quite fascinating.
Yeah, that's interesting. The opportunities kind of seem to be endless. But now that you have surgery, and you point out that a lot of your work is on this area of intersection between imaging and surgery, therapeutic endoscopy and stuff. But I'm assuming that you still do the work of traditional surgeon, traditional surgery, and a bit of traditional medical imaging as well. And I can't think of two completely different branches of healthcare as these two, because surgeons, you think of them as being like very daring and brash and, you know, like act first, think later kind of thing, whereas radiologists are kind of the polar opposite, like in a dark corner, you know, the traditional Sherlock Holmes having a pipe and just staring and contemplating and thinking and thinking and thinking without much acting. But now that you have to shift your roles so much, how do you balance this? Does one impact other? Do you think that being a radiologist has impacted how you think clinical as a surgeon, or being a surgeon has impacted how you think as a radiologist? Or are these different modes? You switch on a mode, switch off a mode. Okay, now it's a radiologist mode, surgeon mode.
You know, it's interesting. I mean, when I was training both in surgery and in radiology, the surgeons and the radiologists I always admired the most were the ones that, you know, the surgeon really wasn't afraid to call the radiologist and ask for, you know, their opinion, or see if things can be done in a different way or less invasive. And same on the radiology side. Some of, like, my mentors that I looked up to them the most were the ones that really kind of embedded themselves in patient care as much as possible, and really kind of took interest in the patient and what was the outcome of the surgery and what were the surgical findings, and trying to correlate them to what was seen on the imaging beforehand. So I think there's a lot of room in that intersection. I think for me personally, it's nice to know what's available for the patient and what are the limitations of the different modalities, right? Like when is it right to try and avoid surgery and offer them something less invasive, and when you kind of reach the limitation of what less invasive things can do, and it's just time to, the only way
old-fashioned way.
heal is with cold steel, and
That's a good one.
and but there's it's a wide spectrum, and it's a continuum, right? I mean, surgery is only getting less and less invasive and more reliant on imaging, and IR is only continuing to expand into new areas and indications, and there's a lot of room, I think, for innovation in those margins.
So you're saying that back in the day, we used to have a lot more surgeons and clinicians coming down to discuss cases with us. And I think across the world, people now say that that's significantly come down. So you're saying that there should be more surgeons willing to come down and discuss things with the radiologists. But in addition, at the same time, there is this pervasive thought or belief among the radiologists is that, oh, the clinicians didn't tell me this, they didn't put it in the indication. Well, the EPR, the electronic health record, is available. Why don't you open and find it out yourself? Oh, well, why don't you call the clinician? Why don't you speak with the patient? So I think that over time, as we get better and more efficient with communication with online meetings, there's less of an actual communication or a crosstalk. And I think that both sides should probably reach out and discuss with each other, because that kind of not only leads to better patient care, but also more innovation overall in general.
Yeah, absolutely. I mean, I 100% agree with you. I mean, when I'm in interventional radiology, I mean, I often, if I'm not sure about the patient or the indication, or can things be done differently, I mean, I don't hesitate to phone the referring physician to just kind of see, and I've never gotten any pushback. I mean, 99 times out of 100, they're extremely happy that you're calling them to see if there's something that can be optimized for the patient, and vice versa. I mean, clinicians call me regularly to see if we can offer the patient something that maybe is slightly less invasive, or can spare them surgery. So and I think that sort of collaboration needs to be fostered. And I think in interventional radiology in our department, I think that works very well. I mean, there's physicians that work very closely with the vascular surgery department, with the thoracic surgery department, and I think overall, kind of the leaders of the department really built a very collaborative.
I remember there was one patient we shared in which, after one of the POEMS procedure you did, we had a follow-up, and I did the fluoroscopy. There was no leak, but there was something odd about it, and I called you, and I was like, there is something odd about him. Just make sure you observe him. And I remember you calling me back on that day after the CT was done to tell me that, hey, you were right, it was a volvulus. So I think it was a great way to show that I wasn't 100% sure what was going on. So I let you know. But then you closing the loop by telling me what it turned out to be, that I was right, that there was actually something going on. We both learned, and it actually led to a good patient care, instead of me just writing a report and sending it to you, and you not having an idea.
Yeah, absolutely. And I love getting these phone calls from medical imaging. If there's something that just kind of looks odd, I know obviously you well enough to know that if you're feeling a bit uneasy about a patient, I should look very carefully to make sure that there's nothing going on. So I really appreciate kind of that back and forth communication.
Do you think that like you've had a formal training both in radiology and surgery? Not sure that every medical student wants to be the same, but do you think that at least some portion of training for radiologists should be geared in surgery, or grounded in surgery, or in other medical specialties as well, and some portion of training in surgery should be grounded in medicine? And trying to bring these together would foster more collaboration, dialogue, and better patient care.
Yeah, no, absolutely. So, I mean, everybody talks about, thinking outside the box, but, I think before you can think about outside the box, you need to kind of know what's in the box. So I think there's a lot of emphasis that needs to be done on getting good fundamental training, in surgery and in medical imaging, interventional radiology. But having said that, I mean, I think the training can probably be streamlined to make it, more accessible for more people. But I can even see, in our trainees, both in IR and in surgery over the last, 5-10 years, there's a lot more interest and openness in learning these techniques. So in IR, our fellows are, very keen to learn these percutaneous endoscopy techniques and the biliary tree, and my surgery fellows are very keen to come to IR, see what we do, get some hand-on experience with some, fluoroscopic guided procedures. So I think there's a lot of openness from the kind of up and coming, fellows and residents to learn this. I think people that are going to graduate in 5-10 years are going to have kind of a completely different mindset and openness than people that maybe graduated when I graduated or before then.
Yeah, it's good that the walls of silos are being broken down, and then there is this collaboration on both sides and both having their own expertise, but then there is a little bit of an overlap in between so that things don't get fallen through the cracks.
Yeah,
so
yeah, absolutely.
it's great that the walls of the silos are being broken down and people are being brought together. But this being radiologist podcast, what specific advice can you give to the radiologists so that their reports are better for what the surgeon actually needs? The reason I'm asking it is that there are quite a lot of papers which come out in radiographics and a lot of other places saying that urolithiasis, what does the surgeon want to know? This disease, what does the surgeon want to know? And when I look at the authors, all of them are radiologists. So now that you are a surgeon, what does the surgeon actually want to know? How do you write better reports to answer the exact question without it being too bulky or without it being too minimalistic? Where does the balance lie?
Yeah, it's very interesting. I mean, I think for me, I guess in the surgeon hat, what I care about the most from the report is really what you're thinking, as the radiologist, how many nodules and so on and so forth. I mean, that's important, obviously, but I guess the most important thing for me in the impression is what are you thinking? Are you worried about the patient? Is there something I need to watch out for? Kind of like that example that you gave that, we're maybe not sure exactly what was going on, but it's just something was off and that, it didn't quite fit. And, you need to be a little bit careful and watch this patient a little bit more carefully. And I think that's probably the most value add. If you tell me, I'm not exactly sure, but there's something wrong, you need to watch carefully. That's maybe the most valuable thing. Just getting your clinical opinion about the patient from what you can glean from the imaging, I think is the most valuable to me, and not being afraid to kind of take the leap and say, I think this is what's going on, and you may be right, you may be wrong, and us as surgeons, we're sometimes right and we're sometimes wrong, but I think that's the most valuable thing is to really get your thoughts about what I should do, what I need to watch out for, what's going on with the patient.
Interesting. So what you're saying is that if you don't commit, you'll never be wrong, but then you're never going to be useless as well. And I think that there is a growing worry among a lot of radiologists that, what if I'm wrong? What if I get sued? And what if something happens? So a lot of times there's a lot of hedging in the report. There is this tiny nodule here. It could be benign, but it could be metastasis. We don't know. We'll just do it. At the end of the day, it's not really clear. But at least if you can tilt it towards saying that, hey, there is a nodule. I think that this is most likely benign. It's a very small chance it could be metastasis, but it's most likely benign. At least you kind of have a sense of what direction to take or what we're thinking. And I think that that's probably what you're pointing to.
Yeah, absolutely. And I think, on the receiving end, when you have a report that's very hedging,
Mhm.
it's kind of hard to know what to do with that,
Yeah.
right? So having, you know, some, I guess, guidance is extremely helpful, you know, on the side that's reading the
The
report.
reports. Amazing. That's an excellent advice for radiologists. But for trainees, medical students, or maybe residents very early in their surgery or imaging career who are interested in pursue something like what you're doing now, who are interested in working in that intersectional area between medical imaging and surgery, what advice do you have for them for success?
I think probably the biggest thing is to get it as much exposure as possible. You know, come to the OR, come to interventional radiology, come to endoscopy. Just see as much as you can. You know, interact with the patients as much as you can, and try and figure out what you like. At the end of the day, like we said, the silos are very artificial, and probably in the end will be broken down. I mean, I started out you know, in a surgery residency and ended up in interventional radiology or in both. So I think it's really trying to see what you love the most rather than picking, you know, which residency, and then you'll eventually find your pathway to that area. But it's just come and hang out and see as much as possible and see what you love, and you'll find the path to it.
That's amazing advice. So I think that getting into medical school is a huge difficulty. A lot of things need to be done to check the box, to clear certain things to get in. But once you're in medical school in your residency, you've made it already. So don't still think about, oh, what do I need to do to get a check mark in imaging or radiology? You're still going to end up being great physicians. So at that point of time, stop worrying about requirements and start worrying about what you're passionate about, what, as you point out, get involved, speak to a lot of people, go to the OR, go to the IR suite, spend a lot of time with patients, because that's the best time we get for all of this. And then, you know, as you have done, they can shape an incredible career, which is very unique, off the beaten path, but incredibly satisfying and extremely creative ways of problem solving for human health. That's amazing.
Thank you. Thank you so much for having me.
Thank you very much, Eran. It's such a pleasure having you here.
Thank you.